Hello, everyone. Good afternoon and good morning. My name is Jen Lee. I'm APJO's Director of Community Services and Partnerships. And on behalf of the Association of Asian Pacific Community Health Organizations, I want to welcome you to today's webinar on understanding and implementing the CMS Emergency Preparedness Rule. I just wanted to tell you a little bit about APJO. We are a national association of community health organizations really committed to promoting advocacy, collaboration, and leadership to improve the health status of Asian Americans, Native Hawaiians, and Pacific Islanders. And a little bit about today's presentation. It's going to be about a 50-minute presentation, and we're going to take questions and answers immediately following the presentation. Just a couple of housekeeping items before I introduce our speakers for today. You should see on your desktop the GoToWebinar control panel, and just a couple of notes on the panel. You're welcome to submit questions at any time during the webinar under the Questions tab there. And if you have any complications with accessing the presentation, please just chat us here at APJO on the chat tab. And hopefully everything will go smoothly. So with that, I just want to introduce the speakers for today's webinar. We're very excited to have them available and hope and know that today's presentation is going to be extremely valuable for many of you. So from Connect Consulting Services, I want to introduce Ms. O'Brien. Nora is the CEO of Connect Consulting Services, which is a healthcare emergency management and business continuity planning firm. She serves as a contributing writer for emergency management and has served as an instructor for FEMA's Center for Domestic Preparedness. She has a master's in public affairs with a concentration in disaster and emergency management. Ms. O'Brien also received the Certified Emergency Manager designation from the International Association of Emergency Managers and currently serves as the chair of the IAEM Healthcare Caucus. Accompanying Nora is Kathy Larson, also from Connect Consulting Services. She is their Director of Planning and Development and is the former Executive Director of Southern Trinity Health Center with years of experience in healthcare emergency management planning. She's also an international search and rescue emergency responder. So we're in great hands today and look forward to hearing the presentation. And with that, I will turn it over to you, Nora.
Hi, thank you so much. I speak for Kathy and I that we're very thrilled to have the opportunity to share with you around the CMS Emergency Preparedness Rule. There's certainly a lot moving parts to this particular requirement, but we hope to give you some clarity at the end of today, and we've provided you a self-assessment tool for your organization to identify where your gaps are for planning, training, and exercises. So today we're going to be talking about understanding, but also it's about implementing the CMS Emergency Preparedness Rule. And we're just thrilled the opportunity. We looked at the registration list and we were just excited to share with all the health centers. And actually there's some folks who are out that are not FQHCs, but from public health departments or nursing organizations or home health. You are all welcome to learn today about the CMS Emergency Preparedness Rule. So let's dive right in. Here we go. So we've got here, you've already heard from us, gotten our little bios from myself, CEO. And what I just have to say that Kathy and I both are big, huge fans of community health centers. I worked for the California Primary Care Association from 2001 to 2009, and we're raving fans. It's just safe to say that we're raving fans of community health centers and understand your challenges and understand the communities you serve, and we appreciate all the work that you do. And Kathy, as our Director of Planning, we have worked together for a long time, and just thrilled to have the opportunity to share with you what we've learned around how to support your efforts in getting to CMS Emergency Preparedness Compliance. So we have it. Welcome. We don't have time all day to do an individual welcome to you all. To have people introduce themselves, but we want to give you an overview of what we hope to do today in the next hour and a half. We want to kind of do a deep dive and have you understand the CMS Emergency Preparedness Final Rule requirements and some ideas about where to get to compliance. And then we've also provided you some implementation strategies and some tools and some tips, and have an opportunity for a lively Q&A session. We think that's important. We also have a couple of poll questions that have been put up, and that information will also help inform how we can best help you, point you to those resources to support your CMS compliance efforts. So what's the impetus for the CMS Emergency Preparedness Rule? There's really three things that it looked at, and obviously it was, September 8th, 2016 is when it was finalized. It really kind of was rooted in, there are a number of major disasters going back to Katrina in 2005, Hurricane Sandy in 2013 and 2012, that really looked at healthcare providers, the smaller providers that, downwind of hospitals that didn't always have the tools and necessary resources to respond to disasters. And really what CMS, the Centers for Medicare and Medicaid Services, really finalized a rule to do three things. Establish a consistent emergency preparedness requirements for all 17 provider types. So it's obviously not just FQHCs. There's, and folks that generally, for the most part, have not had any of these requirements on the federal level before, around, which we'll get into the great detail, but consistently across the board, the same emergency preparedness requirements for those participating healthcare providers that participate in Medicare and Medicaid programs. What they also want to do, and that's always the ultimate goal of CMS, is increase patient safety during emergencies. We all have seen some devastation, really, the last few months. It's not hard to think about how many recent examples that we've had from the nursing home deaths after Hurricane Irma in Florida, and even the wildfires here in California that are not too far from us in Sacramento that are raging, that are impacted. The whole point of those folks that are served by Medicaid and Medicare populations tend to be more vulnerable and in disaster, whether it's kids or whether it's seniors. Those folks really need a little bit more care and support. The other thing is that we know that when healthcare providers and when communities come together and plan together about a community response, they wanted a more coordinated response to both natural and man-made disasters by requiring the whole situation of communicating with your local, state, tribal, and federal agencies, having participating community exercises, which we'll talk about in a bit. Those things are really key. And so that was the intent around what CMS was, what the rule was. The other piece of the CMS rule is that in the past, people have had, and people currently have, plans that are paper plans that they might have 2 or 3 inches thick of dust on them. They're just not operationalized. They're not, it's an opportunity for what CMS is looking at is not just, it's not okay to just have plans, but more importantly, if you're assessing your risk annually, if you're reviewing your plans, etc., it's an opportunity for you to better know how to plan for disasters. So the FQHC requirement for FQHCs and RHCs, they're focused on 3 key essentials: safeguarding those human resources, maintaining business continuity and continuity of operations, and also protecting physical resources like the health centers. Those are the real 3 key essentials. So those are important, and Kathy will probably go into that in just a bit. The other piece we wanted to share about these 4 requirements, so there, and I'll go into them in cursory level, and Kathy can take it from here, but it's really those 4 requirements. Developing an emergency plan based on a risk assessment. So essentially, if you're in Hawaii, and if you're in Hawaii, you probably need a volcano plan, but probably not in Ohio. Just that's the whole point. You develop a plan based on the risk. But in Ohio, you probably need you know, a severe weather plan or a blizzard plan or ice storm. So that's essentially what the intent was there. You also want to develop. They want you to develop policies and procedures that will support effective and efficient response and recovery. They want you to create a communication plan, and these are requirements for all 17 provider types, and it's a huge number of folks. It's 72,000 providers across the U.S. 72,000, and they want you to conduct training and plan testing. So those are the things. Those are the key components. So it's now been in the effective rule date is November 16th, but the implementation is required by November 15th. So you've had a year to comply. You've had time. Maybe that's a case you haven't gotten there yet, and that's why you're joining us today. But that's okay. We'll help give you some ideas on how to get to compliance. I'm going to now specifically head it over to Kathy so she can talk in great detail, because she is our CMS guru here at Connect Consulting, and she can help you get there. All right, I'm going to, let me do the bowl. How do I do that?
Thank you, Nora, and welcome everyone to the presentation today. As Nora mentioned, we're going to take a deep dive into the requirements of the CMS rule, and we certainly appreciate everyone's participation today. Primarily, we'll be speaking about those of you that are licensed as FQHCs or RHCs, because the rules are different depending on which of the 17 provider types you fall into. The kinds of policies and procedures that you need to have, and some of this planning strategies vary from provider type to provider type. So if you are not an FQHC or an RHC, or you fall into some other bucket, please don't hesitate to reach out to me or post your question in the chat about those. But again, predominantly the presentation is directed at federally qualified health centers and or rural health clinics. CMS has actually stepped out and said successful adoption of the CMS rule really is about anticipating and planning using the all hazards approach, which Nora spoke to a little bit. But we want to be able to respond to all hazards, but then go into detail in our plans about specific hazards that are hitting your locale depending on the risk assessment that you do that is required under the rule. We want to be able to rapidly respond as a facility when things happen. We know in the first minute or two of a disaster, when chaos is ensuing, the more quickly your facility can respond and take charge during the disaster, and we'll talk about tips and strategies on how to do that, the sooner your organization will move out of that chaos mode and into action and into response. And that's when things actually start getting better. The longer your organization stays in that chaos mode, the more likely you're going to have loss of life or further injuries and loss of property that may impact your organization's ability to recover. So rapid response is a key component as you're developing your plans, your strategies, and your trainings. CMS is also very clear that throughout your plan and throughout your program development, that you need to be able to integrate with local public health and emergency management agencies. And they specifically address healthcare coalitions. Healthcare coalitions were established after 9/11 when hospital preparedness program dollars started coming out of Washington. And healthcare coalitions were initially established. Since the implementation of the CMS rule, CMS and the federal government has expanded the invitation to these healthcare coalitions for all 17 provider types that are addressed under the rule. So if your organization is not participating in your county's healthcare coalition or regions coalition, every part of the country is a little different on how these are structured. go ahead and contact your local health department and ask them information about when and where the Healthcare Coalition meetings take place. It's a great place to kind of understand what the local planning efforts are, because we understand that when disasters happen, you don't operate in a vacuum. You have partners that come to help you, and different agencies collectively get together to respond for the needs of the community. It might be EMS, it might be fire, it might be police. Certainly your hospitals play a role. And as federally qualified health centers and rural health clinics, we know you play a very, very important role. And actually, we're the second provider type to get invited to the healthcare coalitions when after 9/11 happened and we started seeing the prevalence of disasters become more frequent. So if you need more information about how to locate or contact your healthcare coalition, don't hesitate to reach out to us. My first piece of advice to all of you around the CMS rule is it's getting really close, but there's no time to panic. Remain calm. That's our best advice to you. Remain calm, and then just remember step one, and then keep it really simple. The CMS rule really has 5 parts to it. 4 of them Nora outlined for you earlier. That is your emergency plan, then your policies and procedures that support the plan, a communications plan that can be incorporated as part of your emergency plan, or it could be a separate plan. That really is entirely up to you. The third component under the rule is the fourth component is your training and exercises. And then the one part that a lot of folks don't talk about is your program management. And I think Nora said it very well when she said, remember, it's not just about a plan. It really is about a program. And if you read through the CMS emergency preparedness language, you will see the frequent use of the word program. And it's not really just about a plan, it's about having a program. So we're going to help you get there. Let's start with the plan, though, the first part of your program. CMS says that the FQHC-RHC must establish and maintain an emergency preparedness plan. Here's the key that's new and above and beyond what's in the HRSA PIN, must be reviewed and updated at least annually. So when CMS comes to do their audit, or LNC comes to do the audit, they may ask you about your plan, they may ask to see your plan, they will certainly most likely ask you when it was updated last, and they may want verification of that. It has to be reviewed and updated annually. In addition, your plan needs to be based not only on a facility-based risk assessment, but also community-based. What are the risks that your organization is faced with facility-wide and community-wide? So it might be active shooter or workplace violence within your organization. Maybe internal fire is something that is high on your list that you've identified as part of your risk assessment. And then, of course, you've got your selection of earthquakes, fires, floods, tornadoes, volcanoes, those kinds of things. But your organization will need to do a risk assessment every year. And then based on that risk assessment, you'll want to develop your plan around developing strategies based on that risk assessment. A lot of folks, organizations that we work with, use the Kaiser's hazard vulnerability analysis tool. It's readily available on the internet. They have 2 versions now, the 2014 version and the 2017 version of the Kaiser Permanente risk assessment tool. Just Google it or contact us and we'll be happy to get it in your hands. It's a great little Excel spreadsheet to help you do a risk assessment. It's a scoring tool to identify those highest threats to your organization. Your plan also has to address your patient population, specifically the kinds of services that your organization might be able to provide in an emergency. You need to have continuity of operation strategies within your plan. You also need to include delegation of authority and succession plans. And people are like, wow, what's that? Well, if we look at continuity of operations, you might talk about if your ability to provide services services to your community is reduced because maybe your staffing levels are reduced. Let's say you have an earthquake and roads are damaged in your area and staff housing is damaged, and so you have limited staff availability. What is your plan to accommodate that? In your plan, you might say some of our strategies might include extending our hours of operation or reducing our hours of operation to better accommodate the community with the resources we have available. If you have facilities that are damaged, maybe continuity of operations might include setting up services at an alternate location, maybe a community center or a school. So these are things you'll want to build in to your various plans, whether it's earthquake, volcano, tornado, etc. Delegation of authority just means who's in charge. If you've got executive staff that can't come in or they're not available, they had to evacuate, what is your chain of command and succession planning? A lot of people use the incident command system or a modified version of that, and they have 2 or 3 people pre-designated for each of the positions. Part of moving your organization out of chaos into a controlled response has to do with activating that system where people know who's in charge and what to do. A lot of times when disasters strike, there's a lot of chaos and you have conflicting direction that staff are given, and then staff don't know how to respond. So clearly activating that incident command system and giving direction to staff and patients is a great way to start moving into a sense of order and responding to the emergency. And the more you plan and practice for that, the easier it becomes. The last part of your plan requirements include having a process to cooperate and collaborate with local, tribal, regional, state, and federal emergency preparedness officials. CMS doesn't tell us how to do any of this that you see on this slide right now. They are counting on you to determine how to roll that out because they know that the situation varies from area to area and locale to locale. So you will need to kind of figure these things out as an organization and put them into the planning phase. This is really the bulk of the direction we get from CMS. We get a little more help in the interpretive guidance that came out in on June 2nd, but CMS is very good about letting you figure out how to make these things happen. So part of your plan, as we mentioned, is based on a risk assessment. It needs to be documented. As we know with CMS, if it wasn't documented, it wasn't done. So in addition to documenting your plan and documenting when you update your plan, you need to have a documented risk assessment. And as I mentioned earlier, Kaiser has a great tool to be able to look at what hazards or vulnerabilities that are your highest priorities. It will help guide you toward actions that you might take to reduce the impact of those hazards. And then what resources you need to mitigate, or we know that means prevent or prepare for hazards. So all these things need to be a part of your plan. And just briefly, for those of you that aren't familiar with a risk assessment or how to conduct a hazard vulnerability analysis, these are some of the things that we look at. We look at what's the probability of a particular hazard happening and what impact it might have on your organization, whether it's human impact, property impact, or business impact. And then the ability for your organization to be prepared and then to respond internally and externally. These are all things that your risk assessment will do to help you develop strategies within your plan. Here are a few examples of some of the natural hazards you may consider or that may score higher than others in terms of choosing which hazards you need to incorporate into your plan. Don't forget the technological hazards that we're hearing a lot about. A lot of you have electronic health records systems, whether it's NextGen or ECW or any of the many products that are out on the market. We know that they don't are not always up. So make sure that you're planning for those information system failures, internal fires. Don't forget cyber attacks. really big prevalence right now, ransomware, those kinds of things. Make sure you're including those in your risk assessment. Some of the human hazards that we're seeing more and more that are affecting clinics that you might want to plan for as well include some of these hazards. Active shooters, boy, we're seeing more and more of those. It's something we really should be planning for. We've had patients come in that can to cause disruption with our health centers, and a lot of us already have plans in place for violent patients or patients that are disturbed and come into our health center. So make sure you're kind of incorporating and working together on some of those plans and policies and procedures that you're putting in place. Many of you have de-escalation processes. Use those and incorporate those into your plans around having patients come into your health center that may cause or be a precursor to active shooters or violence in and amongst your organizations. Your emergency preparedness plan needs to include strategies for addressing those emergency events that you identified by your HVA. So what does that mean? So either within your plan or in separate plans that you attach, you need to have hazard response plans that describe really who's going to do what, when are they going to do it, with what resources are they going to do it, by what authority. So for example, internal fire. You should have an internal fire response plan that's either embedded within your main plan or as a separate attachment that really describes what your staff is going to do in the event of a fire, in terms of how you're going to prevent fires in your organization, what are some preparedness activities around fires, and then if a fire breaks out in your organization, what staff should do. You can use this as a training tool. Your fire response plan could be a training tool, and it can also give direction to general staff and management staff in the event a fire takes place. And then by what authority? What is your incident command team going to do if you have a fire? It should describe exit routes. It should describe your assembly points outside on evacuation. If you've got multiple floors to your facility, it should also include floor wardens if you're going to use a floor warden system. And so you want details to your plan so that people know what to do from a training perspective. If you do testing around your plan and you have a tabletop or full-scale exercise around an internal fire, that you're able to use that plan to help you do the training and test your plan in an exercise. If you need samples of what a response plan might look like, reach out to us and we're happy to give you some additional information if you've never seen a hazard response plan before. Also, under the CMS rule, again, we mentioned a little bit earlier that you need to address your patient population and type of service. If you serve a lot of folks that speak primarily a different language, how are you going to provide for that in an emergency? That's part of addressing your patient population. If you have a lot of seniors, if you have a lot of people with disabilities, how are you going to address those in an emergency or disaster? We've already talked a little bit about continuity of operations, also known as business continuity, some strategies built into your plan, and then again, the delegation of authority and succession planning is an important part of your plan. The last part of the CMS rule basically says that your policies and procedures must address management of medical and non-medical emergencies, including but not limited to fire, equipment power, water failures, care-related emergencies, natural disasters that are likely to threaten the health and safety of patients, staff, or the public. And then your policy and procedures section, you have to review those and update them annually as well. So a little bit more about the policies and procedures for FQHCs. Depending on your provider type, your policies and procedures, I think, are the most detailed part of the CMS rule. For example, if you're a PACE organization, you have 10 required policies and procedures under the CMS rule. If you're a hospital organization, there are 8. For FQHCs and RHCs, there are 4 required and mandated policies and procedures that must detail how your organization is going to conduct a safe evacuation. The second policy and procedure is a means to shelter in place. I think the challenging part is knowing when it's appropriate to evacuate versus when it's appropriate to shelter in place. And that's going to kind of go back to your chain of command and your ability to delegate and take control of the emergency. Obviously, if you're having an internal fire, evacuation, safe evacuation in a prompt manner is important to saving lives. If you're having an earthquake, you don't want to conduct a rapid evacuation, because if the shaking is still going on, we know that a lot of fatalities occur when people try to exit the building quickly and the roof or part of the building is falling apart and people are killed by falling debris. And so it's more of a shelter in place using some real specific targeted strategies until the shaking stops, and then you can safely evacuate. So while we've got these 4 policies and procedures, some of them kind of work together in some situations in knowing what to do when. And that's why we want to develop very comprehensive hazard response plans pertinent to very specific situations that are identified in your risk assessment. So earthquake, it's going to be kind of a modified shelter in place that are strategies that we know work well in earthquakes until it's safe to safely evacuate. If you've got an active shooter, we know it's the run, hide, fight scenario that kind of incorporates some of the strategies around safe evacuation and others sometimes shelter in place. So that clear chain of command and direction to staff is very important. The third required policy and procedure under the CMS rule, a lot of you already have. It's a system of medical documentation that preserves patient information, protects confidentiality, and part of that incorporates HIPAA, and secures and maintains the availability of records. So really it's about if systems go down, if your EHR goes down as part of the disaster, one, how are you going to get it back up as quickly as possible so that you can have continuity of documentation? But the second part of it is, do you have policies and procedures in place around essentially what we would call in the industry a go-to-paper protocol? And then once your systems are restored, what are the procedures to incorporate that documentation that was done on paper into your electronic health records? Are we going to key enter it? Are we going to scan it in? How are we going to provide for that continuity? And then the fourth policy and procedure is around the use of volunteers. And a lot of organizations say, well, we don't use volunteers, or we only use volunteers in certain areas, within the community for community outreach. But as we can see with Hurricane, Harvey and Irma recently and the wildfires, sometimes folks just show up and say, I'm a physician, emergency medicine physician, or I'm a family practice physician, and I'm here to help. So CMS is requiring FQHCs and RHCs, and actually this is one of the 4 core policies that we see throughout the 17 provider types. Really what this policy is about is your emergency credentialing procedures so that you can make sure that volunteers that your organization may use meet the safety standards and are authorized to perform the services for you that they claim to have credentialing in. So really it's about emergency credentialing of licensed and certified healthcare professionals. And we've developed a package of policies and procedures that meet the CMS requirements in quite detail if folks need some assistance in that area. The third part of the CMS rule, the third layer, if you will, is around emergency communications plan. And CMS set this out as a separate component. They don't tell you how to comply with this. They only tell you what the pieces are that you need to have in your plan. It can be a separate plan, like we mentioned earlier, or it could be a chapter in or a section in your emergency preparedness plan. The CMS requirement, basically what information they give you to be in compliance with this section, is that you have to develop and maintain, here we go, that maintain again, a communication plan, and they say that complies with federal, state, and local laws. That's a clause throughout the CMS rule. And again, must be reviewed and updated annually. Not much help so far. The part that's helpful is that your communication plan, you have to keep a list of your names and contact information for your staff, any folks that you contract with, including physicians. You also have to have names and contact information for other FQHCs and volunteers. And you need to be able to keep that in a way. You need a process to make sure that information stays updated. There's nothing worse than having to contact staff and then you can't get through because the contact information you have for folks is old. So make sure that you have a process to keep that information updated. You also have to have contact information for those entities that you're supposed to be cooperating and collaborating with, those federal, state, tribal, regional, local emergency preparedness staff and other sources of assistance. And CMS doesn't tell you who those folks are. They're counting on you to figure out who they are. I like to direct people to your healthcare coalition, go to the meetings, see who's involved in your local planning efforts. And that's a great place to start, because once you get there, then you can have the conversation about, well, how are people communicating? Is ham radio big in your area? Are people using satellite phones? If you're in a more rural, remote area where it's very mountainous, a lot of times people are on satellite radios because the 800 megahertz radios just don't cut it in the mountainous terrain. But a lot of areas do use 800 megahertz radios, but it won't do you any good to have one if you don't know the frequencies that everyone is on. And so I think more important than any of the other components, your communication plan really needs to be developed in conjunction with that healthcare coalition. Also, I recommend people collaborate with their local fire departments that are closest to your health centers. Invite them to your evacuation drills, your fire drills, and have them give you some feedback on any recommendations they may have, like the location that you're choosing to assemble outside. If you have multiple floors, the way you're evacuating and managing going from floor to floor. If you're going to purchase stair chairs and practice with those stair chairs, invite them. They'll be a great resource for you. They will tell you if your evacuation route crosses a path where their fire trucks may run over you. That's really important stuff to be collaborating. Your plan also has to include primary and alternate means of communications. We know when earthquakes and major disasters like fires happen and tornadoes, people try to use their cell phones, they don't work. And sometimes it's because the towers are damaged, but more often than not, it's because of overloaded circuits, and you get that all circuits are busy. A lot of times our telephone systems now that we have in health centers go down because power goes down, and we're all on IP phones. Don't forget about those fax machines that you may still have in your health centers that are on the plain old telephone service lines or POTS lines that we may have in our health centers. If you go digital on your fax machines, make sure that you're preserving some of those lines, because you can plug in the old corded phones, not a cordless phone, they'll go down as well, but those corded phones, the old rotary phones, for example, will often still work in a disaster, so you'll want to plan and test for that. The other requirement under the communication plan is a means of providing information about the general condition and location of patients under the facility's care. And this actually is a CMS requirement, but it's also a disaster clause in the HIPAA regulations where it's okay to release this information in times of disasters. We know, for example, the Red Cross is very big on trying to put families back together following a disaster when we have a lot of evacuations going on. Right now, we have one of the largest wildfires in California history going on in Sonoma and Napa counties. It's an urban wildfire. It's very unique in that it's a very massive urban wildfire that's going on right now, and they've evacuated about 20,000 people to date, and we've got over 150 people that are unaccounted for. And so right now there's a lot of efforts to try and report where folks are. So if you're sheltering in place or you've evacuated and people are assembled in your parking lot, it's okay to release to the Red Cross or other emergency officials who you've got there so that we can kind of take an accounting and put folks back together. The last part of your communication plan requirement is a means of providing information about your needs and the ability to provide assistance. So really what that means is when you call in to the Emergency Operations Center or the EOC, you want to be able to say, we're ABC Health Center, we're okay here, we're sheltering in place, 75 patients and staff, we're getting a little low on water, we could use some water here. We need some more, the fires are really bad, we could use some albuterol, for example, whatever your needs are. But then you need to be able to also report what you can provide. We have 3 doctors that came into work today that we can release to the surge tent at the hospital or whatever. So it's about what you need and what you're able to provide. And that constitutes the core requirements of what is mandated as part of your communication plan. The last part of the CMS rule has to do with training and plan testing. And there's 2 parts to this. The first part is training. And so all of your staff and volunteers, contractors must be trained prior to the November 15th of 2017 deadline on your emergency plan and your policies and procedures. They must receive training. And then you need to set up a system where you're training those folks annually, and the new staff that come on board as part of the onboarding process, they need to be trained as well in your emergency plan and your policies and procedures. In the exercise portion of the requirement, your organization is required to conduct and document 2 exercises every year. One of them must be a community-based full-scale exercise. And then the second exercise can either be a second full-scale exercise or it can be a tabletop exercise. And I know initially when the CMS rule first came out, people really panicked, because if you go to the FEMA website and you Google full-scale exercise and you look at what a big endeavor and massive it is, and if you talk to emergency managers, they're like, oh yeah, that's a 6-month or a year process to put one together and plan for it. CMS, in the interpretive guidance that came out June 2nd, they clarified for us, thank goodness. And they said, well, the term full-scale exercise can vary by what they call sector or locale. And so facilities are not required to conduct a full-scale exercise as defined by FEMA or DHS, their HC program. So CMS said, for the purpose of this requirement, and this is right from CMS, word for word, a full-scale exercise is defined and accepted as any operations-based exercise. So in other words, under the CMS rule where they say full-scale exercise, they really mean a drill, functional, or full-scale exercise if you look any of those 3 items up under FEMA or the HC program. But again, documentation is key. The purpose of doing an exercise isn't to test your staff or your people, it's to test your plan. So if an earthquake is high on your risk in your risk assessment and you write an earthquake response plan, then you're going to want to test that plan by doing a drill, functional, or full-scale exercise to test the plan. Then after you do your exercise, you do a roundtable, you talk about how it went, you write up a report. Part of your report would be your improvement recommendations. Often in emergency management, we call that our after action report and improvement plan. And then CMS is going to actually look to see on that report if you have any suggestions for improvement. If you do, they're going to want to see your actual plan to see if you implemented and rewrote and updated your plan to reflect those recommendations as a result of your exercise. And then your second exercise requirement can be a discussion-based exercise, also known as a tabletop, is one example of that. A couple of key concepts where we see organizations have been really successful in implementing a program. Part of it is leadership support, top down. We want to make sure leadership is involved. Leadership is engaged in incident command system or ICS training so that you can have a good chain of command during a disaster. That leadership is involved in the planning process and developing the policies and procedures, and that leadership supports a multidisciplinary approach. In other words, we know when requirements like this come out from CMS, the first thing our leadership does, and I was guilty of it myself, we assign it to one person and tell them that they got to get this done, and it might be the administrative assistant, it might be the facilities coordinator or manager, it might be a nurse or a safety officer, but generally it's somebody who already has a full-time job and doesn't have enough hours in the day to begin with. And it's one person stuck in a room trying to write a plan. It won't work in this situation. It really won't, because of how comprehensive the program requirements are to have the plan with the depth that it does, and to have the policy and procedure requirement and the training and exercises. If you can put a team together or incorporate an existing team that you already have, do you have a safety team? Do you have a quality improvement team? Where can you put this without creating something new that could take this on and expand? Your training and exercise program, does it need to be a separate program? We already know that in health centers, you're required to do a lot of annual training already around bloodborne pathogens, hazardous materials, that kind of stuff. Just add it in and incorporate it to what you're already doing. Your policy and procedure process, that review process, and how policies and procedures are put together. Incorporate it into what you're already doing, but try and put a team together so you're doing this with a team approach with support from leadership, and then integrate it as best you can. CMS doesn't tell you what format your plan needs to be in or your policies and procedures, but they just tell you what components have to be in there. So try and incorporate it into what you're doing. When the surveyor comes, they're going to want to see documents. They're going to talk to your people. They're going to want to see your plan. They're going to want to see your training records. If you think about your CMS surveys that happen now, oftentimes they'll grab that medical assistant in one of your clinics that is having trouble making eye contact with their surveyor, and they'll ask them a question. You know, tell me how you do this, or tell me how you do that. Tell me about your plan. And so they will question your staff, they'll question your leadership team, but they'll look for documentation and ask for training records. And if you're running around trying to find the pieces because they're scattered somewhere else, it will be more of a challenge for you. So we like to advise folks that while a lot of this stuff is integrated, it's nice to have a binder on site where you've got your plan, your emergency preparedness plan, your communication plan, all your policies and procedures and training records in one location, and evidence of your exercises, and then your evidence of your staff trainings, so that you have that all in one place. It sure makes it a lot easier when they come on site in terms of doing the survey. Before we get into a few questions and discussions, we did want to talk about a little bit about where your organization, if you haven't already started, where do you start? Or if you have started, how do you make sure you get everything covered? Well, Janis Joplin always said, now that I'm here, where am I? And where you start really depends on where you are. So how do you figure that out? Step one, when we work with clients around getting them to CMS compliance, we go through the basic understanding of the CMS rule. We've done that for you today. The next step really is to do an assessment to evaluate where you are. And we're going to give you a tool. You can actually download it as one of the handouts. I wanted to briefly share it with you. When you go through our self-assessment tool, hopefully it will help you find where you currently are so that you can develop a gap analysis or a roadmap of where you get to compliance. And then in terms of maintaining compliance, just remember that everything, all of the requirements have to be met every single year. You have to redo your risk assessment. We also call that the HVA. You have to review and update your plan. You have to review and update, if needed, your communication plan. And you have to complete your 2 exercises and then your annual trainings, and then, of course, your onboarding for new staff. So that is a cycle that must be done every year. So if we take a look at our little self-assessment tool, I'm actually going to bring it up here for you. If you haven't had a chance to download it, where did that sucker go? Let's get it back over here so you can see it. We put this little tool together for you that you can download. And basically the first page of this little self-assessment tool is really about best practices. This first page isn't as much about what's in the CMS rule, but some strategies around getting to compliance and maintaining compliance. So really it's about, do you have leadership buy-in? Do you have support? Have you identified what your organization's role in helping your community? CMS wants you to identify, what your role is going to be in various disasters. You need to do that in order to kind of develop what your plans are going to be. And so page 1 really is about organizational readiness to implement and get to the compliance with the CMS rule. Section 2 of our little self-assessment tool are the specific requirements addressed within the CMS rule. Now in here we call it our emergency operations plan, just another term for emergency preparedness plans. Some folks call them emergency preparedness plans, others emergency operations plans, others emergency management plans. What we call it, it doesn't matter. What really matters is what's in the content. So here's a way for you to actually score your organization, with a 0 if you haven't addressed it at all, 1 if you're just beginning, 2 if you're part done, or 3 if you've fully met that requirement. You can go ahead and score yourself, and we have various sections of the various requirements of the CMS rule to go through and score yourself. We left you a little note column over here in the right-hand side so that you can make notes in there about your self-assessment. Maybe you're going to put a page number in there that's part of your plan where you meet the compliance, or maybe you're going to put yourself a note that you did an HVA, but we haven't looked at it for 2 years and it needs updating. So that's a little note box for you where you can put that in. But basically, we have all the various sections of the CMS rule in here so that you can self-assess and score yourself. And then there's some references in here to where you might find how to look at the rule yourself if you are so inclined. And then we've got a little scoring system down here to kind of encourage you to recognize that anything that you've done up until now is a start, but also recognize we're getting really, really close to the November 15th deadline. And so that is our self-assessment tool that will help guide you to finding out where you are so that you can actually get yourself further on in the compliance world. There we go. We were going to take some time to actually go through this question by question and kind of take some hands-on time, but I think I'd like to have more time for questions. So if we could, if possible, Jen, do we have any questions from the audience today?
We have several. We also have the poll. So did you want to proceed with the poll, or should we dive into questions straight away?
I'll let you decide since you can kind of see where we're at. How many questions do we have sitting there? I want to make sure we have time for the questions.
We have about 12.
Okay.
Yeah, we could.
Let's go ahead and knock off. Let's hit a few questions first.
Yeah. Okay. Sounds great. So first question is, there's a health center member who's currently using the Kaiser vulnerability assessment tool for their risk assessment. Any recommendations that you all have as to how they gauge the threshold score for development of their emergency plan if their score may be low in terms of probability of disaster happening?
That's a great question. Everybody does the Kaiser. I love the Kaiser tool, and I'm not sure if you're using the 2014 or the 2017 version. For those of you that are using the Kaiser tool, everybody has their own preferences. Some people say I like the 2014 version because it gives me 3 tabs, one for each of the categories of hazards like human, technological, that sort of thing. I like the 2017 version because it actually gives you a tab to document both actual plan activations where you had an emergency or disaster, or you can also document your exercises that you've done, which will then in turn actually lower your risk score because now your organization has muscle memory or you practiced that particular plan, whether it's hurricane, tornado, or volcano or whatever. The number of plans that you actually write and what your threshold is using the Kaiser tool really is up to you. Sometimes people use that scoring tool and none of their scores look very high. And they don't know, do I take the top 3, the highest 5? And I'm going to say that's really up to you. You can't have too many plans, but you want to make sure that you've got at least the top 3 or 4 things that are going to happen. And you want to make sure that you do have a good mix of human hazards to natural hazards and those kinds of things. But their CMS doesn't address, from our perspective, I typically say I like to see 4 or 5 at least, because then you're well versed. If you have too many, then it's hard to train on all of them. But I would say make sure you're dealing. Everybody should look at internal fire. Those can devastate an organization and have tremendous loss of life. You need to have internal fire. I would suggest everyone have some type of workplace violence. If you're in a more heavy, urban area, although that's not the case so much anymore, whether you do active shooter or workplace violence, some kind of human thing in there. Your disaster recovery strategies for your IT department probably address cyber, so it would be easy to craft something that staff could be trained on. But think of your hazard risk plans, whether it's a fire response plan, earthquake response plan, tornado response plan. Think of them as little snapshot grab and go plans. I like them separate from the core plan, but referenced and tied in and associated. Makes them easier to update every year, makes it easier to train on them, makes it easier to do exercises, roundtables on them. But they need to be, I would say, the top 3 to 5. There really isn't a threshold number, though, that I could advise you on. But if you feel your earthquake risk is higher than flood, for example, but somehow flood scored higher, do the reality check and just grab those top 3 to 5.
Got it. I think this is a good follow-up or clarification to the first question, Kathy. Just do these hazard-specific plans need to be completed, or can they be category-specific, like in terms of evacuation, shelter-in-place, or notice of service interruption?
The CMS rule is really clear that you have to have strategies within your plan that address the risks that I identified in your risk assessment. And here's how I like to explain it. I think that is probably the most clear. Think of your policies and procedures as being an all hazards approach. So your safe evacuation policy and procedure is what you follow whenever you need to evacuate safely. Whether it is tornado, fire, it doesn't matter. That's where your all hazards approach falls in. Same thing with shelter in place. This is your shelter in place guideline. So let's say in your earthquake plan, you talk about how to prepare for an earthquake. You have strategies around, prevention, like we're gonna attach our file cabinets to the wall so no one's injured when the cabinet falls during an earthquake. And you're gonna talk just about earthquakes in your earthquake response plan. You're gonna talk about what to do, the duck cover kinds of things. What are we gonna do following an earthquake? But then you might say in your earthquake plan, when the shaking stops, staff will follow the safe evacuation policy and procedure to evacuate the building. So you can reference it. What I don't like to see is people giving specific directions in two different places, because then when we update one of them, they might conflict with each other. So that's how I like to flow them together. There are no requirements around how you do it in the CMS rule, but as a guide, that's kind of how I like to do it. Policies and procedures are all hazards, and then your specific plans and strategies specific to those risks identified in your risk assessment goes in those hazard response plans. We're happy to share some examples on what that looks like in more detail.
Great. So next question, our health center's plan is our policy and procedure. Is it okay if these are both incorporated together?
Yeah, well, once again, CMS doesn't tell us how to do it. They just say what you need to have. We've worked with an organization that had 50 policies, and that was their emergency preparedness program. They just had 50 policies. And if you could dive through them and find all the pieces and parts of the CMS rule, if you can clearly find those 4 requirements and all the detail within those, absolutely, if that's what works for your organization. I know in FQHCs, we're really huge on, everything is a policy and a procedure. And as long as it meets the core requirements, and we're happy to do a review for you to see if you feel that you're dotting the I's and crossing the T's. A surveyor comes and they say, I want to see your emergency plan, and you hand them a book of 50 policies and procedures. Obviously, it's their interpretation whether it meets the requirements of those components. I always like to say, if you want to, look like a duck, you shouldn't look like a fish. And so we try to encourage people, if your entire emergency plan is embedded in policies and procedures, try to get it in something that kind of looks like a plan, because that's what the surveyors are going to be trained on. But certainly you could argue if all the pieces are there, the CMS doesn't tell us how to do it or what it should look like. Hope that helps.
Got it. I know we're kind of focused on FQHCs and RNCs today, but just a quick question. In a skilled nursing facility, who are your, quote, contractors considered to be?
Okay, so a lot of times in skilled nursing facilities, some of the services we provide directly, other times we provide those under contract. And so those contracted entities that are in your facility providing services need to be trained in what those procedures are. Because now you're in an inpatient setting, and so those requirements get a little bit more comprehensive. And one of the services that we do is we offer a free 30-minute consultation to folks to help them figure things out and give them some direction. You folks that are on the call that are in something other than FQHCs that we haven't addressed, and certainly FQHCs, you're happy to contact us as well. But we're happy to give you a little bit more specific guidance. But you would have to, I would suggest going to the people that does your contracts. And if you've got any contracts with folks that are providing those kinds of services, that come in and provide services within your facility, then they're going to need to know. For example, let's just say you have a contract with a dentist, and that dentist comes in and provides oral health care services within your facility to some of your skilled nursing facility patients. That contracted dentist would need to know what your policies and procedures are around safe evacuation. In the event that they would need to know where the exits are, the location of your fire extinguishers, I would do a safety orientation with them their first time coming through. That might be one example.
Okay. So next question is, does an actual emergency count as a full-scale exercise?
Great question. There is a provision in the CMS rule for actual events occurring. And in order to get credit for that full-scale exercise, there's some requirement parts that need to be done. First of all, you need to activate your plan. So it's not just, oh, we had an emergency, we get a grace period for a year. Doesn't work that way. You're going to get credit for an exercise when you have an actual emergency or disaster where your organization activated your emergency plan. Let's say you had an earthquake and you activated your earthquake response plan. The next requirement is that you write up that report following the actual event, that after action report, as we call it, an improvement plan. There are forms you can use to guide you. They're not mandatory. But you write up that report about what happened. Then if your organization has any recommendations to make improvements to that earthquake response plan or emergency plan that you followed, that you document that in your report, and then CMS is going to look to see if you actually implemented those recommendations for improvement and updated your plan. So you got to activate the plan. In the rule, it says if you had an actual event where your plan was activated. Okay, so you got to activate that plan, do your after action report, write it up, make recommendations for improvement, and then go back to your plan. And if you had any suggestions, to implement those recommendations and update your actual plan. So those are the steps required in order to get credit for an actual activation. Doesn't have to be presidentially declared. There's rumors floating around that it does. It does not. The kicker is, did you activate your plan? And then the reporting and the documentation around it.
Got it. So next question, Kathy, is if you could give some examples of internal and external communication systems.
Sure. One of the things that internal, how are you going to communicate with staff? Now, let's say you're an FQHC and you have 10 sites. How do the sites talk to each other? Well, normally we do it through the internet, email, texting, telephone calls. What is your primary way that you're going to do it? And we, like I said earlier, we recommend that it's not just your regular telephone system because often it goes down. And so a lot of folks that we work with, if their clinics aren't too far apart, we recommend that they test out and use walkie-talkies as their primary source of communication internally in a disaster, because you can get the ones that have a fair distance to them. There's some really cool apps that came out that hit the national news media following Hurricane Irma. We heard a little bit about it with Harvey, but the big one, it actually jumped out at us. There are apps that you can download to your cell phone now that turn your cell phone into a walkie-talkie. And there are several of them out there. And when cell service is down, we found that these apps work. So the reason it's important that you have this in your plan is because staff need to know how they're supposed to reach out and communicate to you. So communication is always two ways. So what is your plan to talk to your staff? How are you going to do it in an emergency? That's the internal. Is it going to be text messaging? Is it going to be walkie-talkies? Is it going to be plain old telephone systems, POTS lines, and then how many people even have plain old telephone lines at home anymore? But that's something you're gonna have to figure out what works best locally, and you want to test those things out. But staff need to know, that's why we put it in a plan, and that's why we say primary and secondary, so that if our cell phones don't work and that's our primary plan, do we have text messaging second, or do we have walkie-talkies second? Don't just pick our internal telephone system and cell phones, because neither one of those are, in common sense, tells us will work. Externally, what we mean by externally are those, how are we going to communicate in a primary and secondary way with the Office of Emergency Services, OES, or the command center, the Emergency Operations Center, because we know we have to report what we need and what we have to the EOC in an emergency, or whoever the locally designated center is going to be that's managing the disaster. And it's not going to be all your clinic sites that are going to do that. Your clinic sites should report to your admin. Maybe each office manager is going to be the designated incident commander for that site. And then your incident command team is going to be at your administrative building that's going to be getting reports from your various locations. And then it's that admin site, that incident command team for the organization that's going to report to the Emergency Operations Center, the EOC, that's running the disaster for your, primarily it's a county by county basis. Other times it could be a regional effort, but generally it's county control. But you'll need, that's why we suggest you go to your healthcare coalition meetings, so you find out what these communication primary and secondary systems are that people are using in your county or your locale. But primary and secondary means, what's our first option, what's our second option, be realistic of what might work and what might not work in a disaster. And then internal means your staff, external is your public safety and everybody else. We're not going to just everybody call 911, because then it overloads the 911 system. You're going to want to go to the healthcare coalition meetings, find out how people are going to communicate, who's the designated incident command for the county, and then you'll figure that out when you go to those healthcare coalition meetings. Does that make sense?
Yeah, I think so. So another question, Kathy. How can folks get samples of the 4 required policies and procedures?
Let's see, what do we have here? We actually have, let me get over here and put it up, if I can find my cursor. We actually have put together, that's a great question. We've actually put together some toolboxes that actually have a document that tells you all about the CMS rule. We've included the document that we've handed out today, the assessment tool. We actually have a plan template that's designed specifically for your provider type. And we have actual templates for up to various response plans templates. So we have a sample hurricane, earthquake, fire, flood, all those things. And it also includes our 4 policy and procedure templates. We're happy to send out, one of the templates to folks, but, recognize that we have these as part of our toolboxes that we're happy to provide to you and give you quotes on what those things cost. We've made it really cost effective for health centers. We've got a discount for APCHO folks, APCHO members, and we've got an additional discount we're looking for folks that are participating in the call today. But we made it super simple so you can do the do-it-yourself package. Do it with you package really is about giving you the do-it-yourself toolbox, and then we build in however many hours you think you might need to provide technical support to you to kind of do it yourself. We're getting a ton of calls right now from folks that are just like, we don't have the bandwidth. I got this project 3 months ago and I only get an hour a week to do this. We're not going to make it. November 15th is right around the corner. Can you just do it for us? And so we've tried to make it really simple and cost effective for folks. But We've got our contact information that we will put out to how to contact us, and we're certainly happy to work with you individually to get you folks samples or a proposal on one of our packages. But we've made them really cost effective. We've got great FQHC discounts because staff from Connect Consulting Services are so invested in FQHCs over the years. It's why we get up every day, to be honest with you, to find a way to continue to provide service to such great organization. And so we've tried to make it really simple and cost effective. If you want contact information, you can reach out, to any of us, go to our website. But we are really committed to seeing all the folks we work with get to compliance on time and help them build programs so that they can maintain compliance.
Great. So several more questions that
yeah, I'm here. Keep going. We're doing good on time. I think we're here.
Yeah, and I wanted to let folks know I've gotten several questions that we will be sending out a copy of the slide deck today, the full recording, and the handout to make sure you all have a chance to grab all these questions and have every resource from Kathy and Nora today. So next question is, if we as an FQHC have 3 separate buildings or sites, do we need to have a risk assessment for each building? The policies and procedures for
question. Great question. So there is something in this is a super question, because I don't know. I know very few FQHCs that there's just one building. CMS is real clear within the rule that the rule pertains to each licensed facility. So if you're an FQHC organization that has 3 licensed sites, so they're full-time sites, they're each one is its own FQHC and has its own CMS number and all that stuff. It's not a satellite of another site. It's not an intermittent school-based clinic or something like that. But it's based on which of your licensed sites. Each site has to each site has to have either its own risk assessment, or that risk assessment needs to incorporate all the sites. So the way I like to coach people on this one is CMS has a clause within the rule. It's the last section. They kind of buried it at the end, and it's called integrated healthcare system. And so this applies to a lot of different organizations. Sometimes we see a hospital that has a nursing home and maybe also a physical therapy, outpatient surgery center, PACE organization. That's one model of your integrated sites. But also if you're an FQHC and you have 3, 4, 5, 10, a dozen, 50 sites, whatever, you can do the integrated model. But when you do your risk assessment, it has to take into account each of those locations. And this is really important, because you might have one site that's maybe a little bit more rural, and so maybe its #1 hazard is a wildfire. You might have another site that's more urban based, and so maybe you're more subjective to an active shooter, or bigger buildings, and so it's more likely to have damage due to earthquakes and more impacted because of earthquakes. So it's very important that each of your licensed sites either does its own separate HVA, or you do an HVA. I like to just have each one of my sites do their own HVA. And then when I compile my plan, I take those risks from each of those separate facilities and I incorporate them into an integrated plan. Instead of having each site have its own plan, we then develop an integrated healthcare system, integrated plan for the entire organization that reflects the individual risks of each of the individual sites. And then your policies and procedures, obviously you're gonna, probably most organizations that have multiple locations, they have agency policies and procedures for the agency that incorporates all of the issues for the various locations. But don't forget to take into account what's unique to each of those sites. For example, your safe evacuation policies and procedures are going to have nuances that are specific to that site. Some of your sites maybe only have 1 floor. Some of them may have multiple stories, and so you may want to incorporate floor wardens. So it's okay to have one policy and procedure for safe evacuation, but make sure within that policy and procedure that it addresses things that are specific to that facility. The other thing I want to caution folks, since we brought up the subject of multiple sites, make sure that you have your sites participating in the planning process, because that's part of the requirement for an integrated healthcare system plan and program. Make sure they're participating in the drills and exercises. So what we have our clients do that have multiple sites is we make sure that each site is doing their own evacuation drills and their own testing. Then if we do a tabletop, for example, then we can incorporate all the sites in the tabletop exercise and maybe test our communication plan so that the administrative site, their incident command team is sitting around the table and they're communicating with each of the sites as part of the tabletop exercise, so that that participation by each site is clear and evident and documented. And then you can either do a full-scale exercise at your different locations or incorporate them, or have each of your locations do that simulated internal fire or simulated earthquake that incorporates shelter in place or safe evacuation, so that people are getting to test their plans at that site level. So you can have an integrated, one plan and policies and procedures, but make sure you're incorporating each of your sites, and that each of your sites are participating on the planning part and in your testing and exercises. And all staff must be trained. Initially, annually, new staff onboarding must be trained. Hope that answers your question.
So one other question, Kathy, was, given what's the likelihood that an FKHC will be surveyed given the multitude of health organizations impacted by the rule?
Okay, great question. That's a great question. I think that's only the second time in all our almost a year of doing this that I've actually heard that question. CMS is not going to do a separate survey on the emergency preparedness rule. People are being trained now, surveyors are being trained on how to incorporate this rule into the existing license and certification surveys. There's actually 44 elements that have been identified. They're putting them in what's called an E-tag category. If you go to the CMS website, you can download the actual Excel table that lists all 44 of those what they call E-tags, which are coded numbers to identify the 44 elements that comprise this rule that incorporates 17 provider types. So if you're an FQHC or an RHC, your organization will be held to 20 specific elements out of those 44. If you're a PACE organization, there are 25 of the 44 elements that you'll be held to. And we have documents that identify which those are. But the surveyors are being trained on how to survey for the emergency preparedness requirements as part of the existing surveys that CMS is trying to make sure that everyone gets at least every 2 years. And then if there's anything that comes up in the interim, maybe a patient complaint or something that happens that would trigger a CMS survey, then you may get one that's spontaneous. Your plans, if you're part of a healthcare plan, county for CMS, you're part of a CMS health plan that's managing your Medicare and Medicaid, you may get the survey by the health plan member. Here in California, we've seen partnership health plan getting around pretty frequently and doing not just the every other year surveys, but they're also doing quite a few surveys that have been triggered by patient complaints against the organization. And so once they're in and they start surveying, they can really ask to see anything. And I just kind of have a sense, you know, back after 9/11, when FQHCs, when HRSA put out the 2007-15 PIN mandating that FQHCs have emergency plans, that was never incorporated into the HRSA site audits. But now, with the prevalence of disasters in this country, that's one of the reasons CMS came out with this rule. They're actually incorporating it into the survey, and CMS is getting pretty serious. Even if we look at the nursing home disaster where 8 people lost their lives, if we do an analysis of what was in the CMS rule for nursing homes against what happened, it really, you know, the organization has since lost their CMS privileges as a result. And so we can see this wasn't even a result of a site survey. It was a result of an actual incident that happened. And so I think CMS is very, very concerned about patient and staff safety. And with the prevalence of disasters that we're seeing right now, it's not a matter of if you get surveyed, it's really a matter of when. And just remember, this isn't just about CMS and surveys. It's about your organization, you know, its ability to save lives and your organization's property and resources when a disaster happens. And the ability to be an integral part. We're working with a health center right now, West County Health Centers. I'll say their name. They're right now they're in the western portion of Sonoma County, and they are actually have a very robust emergency plan. A lot of their planning has been around predominantly floods and earthquakes because that's their 2 highest risks. But they're right in the midst of this massive urban wildfire right now that's going on in Sonoma and Napa counties. And because of their resilience and because of their planning efforts, I'm so proud to say that this FQHC is going in to the shelters and providing healthcare services for folks in need as one of their efforts to support their community during this disaster. And if you stop and think about disasters right now and you watch the news, one of the first things that people always say is, I had to evacuate so fast I left my medications at home. And if you stop and think about what happens if people stop abruptly taking really critical medications, you know, the consequences of that. And just the fact that this FQHC is going into the shelters to address people with respiratory difficulties and the massive smoke that's there right now, and helping support people that have left their homes without their medications, for example, and the role that they're playing. Super proud of this organization. They could have just closed their doors and said, you know what, we'll open our doors when the disaster's over if our clinics don't burn down. The fact that they're immersing themselves in the community, I'm just super, super proud of them. We've seen the Kaisers doing it, we've seen large organizations do it, but who knows those folks better than you guys, the FQHCs and the rural health clinics in these organizations. And those of you on the call that are not those organizations, that are the nursing homes and things like that, what can you do? What is your ability? What services do you think you can provide in a disaster? The more you plan, not only will your organization be able to reopen to full capacity after disasters happen, and we know at least 1 in 4 do not, and some statistics are as high as 60% of businesses fail to reopen following a disaster because it takes them too long to get back on their feet and they can't financially sustain. How long can your organization continue to pay salaries without that revenue coming in? These kinds of things are just critical. So yeah, it's about the CMS rule, but really it's about responding for your community in the event of an emergency or disaster, and then being able to open your doors again and recover when something happens.
Great.
That's my soapbox. I apologize. I really go into teacher mode on that one, on professor mode, as Nora calls it. Really passionate about that one. It's about saving lives, really. And if anyone needs further clarification or assistance, or you don't know where to go, please reach out to us and make an appointment for that consultation and see what we can do to help.
Perfect.
Jen, anything else
Thanks
we could do?
I think that's it. You know, I just want to thank you both again, Nora and Kathy, and Connect Consulting Services for providing all this information to folks. Just to reiterate, you know, we will be sending out a copy of the recorded webinar today and the slide deck, as well as, I think a few of you had a hard time downloading the handout, so I'll be sure to email that out to all registrants for the webinar, so you have all those resources to share accordingly. And just want to encourage you all to please connect with Nora and Kathy. They obviously have just a lot of expertise in this area, and excited about what they can offer. So thank you all so much. And I think there were just a couple of questions that I'll make sure that I forward to Nora and Kathy and package up in the email to everyone on the webinar to make sure everybody's questions got answered. But that is it for today.
Thank you, Jen, and thank you, everyone. And thank you for joining us on the call today. We really appreciate it.
Great. Thanks so much, everyone.